This lecture is about hyperkalemia and hypokalemia. We're going to be looking at low and high or elevated potassium levels. Potassium is present in the average body at approximately 50 milliequivalents per kilogram, and 90% of that's intracellular. 8% is within the skin and the bones, and 2% is extracellular. So this maintenance of that small amount of extracellular potassium is critical, about 2%. Both low and high levels of potassium are associated with cardiac arrhythmias, neuromuscular symptomology, and death. When we do think about both of these conditions, we can put it into two categories, acute or chronic. Our main focus today is acute, but I'm going to compare a few things because it helps you understand both conditions. Acute hypo or hyperkalemia can develop within hours to days, chronic weeks to months. Look at these levels of hypokalemia, review these, and hyperkalemia. The mild low potassium is 3.5 to 4, moderate 3 to 3.5, and severe low potassium is less than 3. Hyperkalemia, mild to moderate, is 5.5 to 6.9 milliequivalents, and severe is greater than 7 milliequivalents. In most cases of hypokalemia, they're caused by drugs. It's drug-induced. In most cases of chronic hyperkalemia, renal failure is the cause. So let's look at pathogenesis. Potassium balance is affected by intake, excretion, and internal potassium regulation. Excretion is primarily through the kidneys and the GI tract. There is a small amount of potassium secretion in our perspiration. I do want you to look at box 209-1 on page 1109 and look at the causes that are listed in that box of both hypo and hyperkalemia. Clinical presentation. The very first thing that I want to drive home is that prevention is essential. Okay, so major hypokalemia symptoms are musculoskeletal. You can see flaccid paralysis, you can see ventricular arrhythmias. Usually the ECG changes are ST segment depression, flattening and inversion of the T wave, and a prominent U wave. Major hyperkalemia symptoms are generally cardiac, although you will see some neuromuscular symptomology occur in hyperkalemia. The ECG will reflect a peak T wave, which is often the first sign of hyperkalemia. The ST segment is depressed. There's a widening of that QRS and PR interval and a loss of the P wave. Late signs of severe hyperkalemia is called a SYN wave. Look to your left pattern. That usually implies that ventricular tachycardia is about to occur and then asystole, which implies death. Physical exam, the most important part is a thorough history prior to the physical exam. You know, I say this almost in every lecture, 85% of what we do is a history, and then the physical exam takes about 15% or less of our time. Be sure that vital signs include orthostatic blood pressure assessment, volume status, and the neuromuscular system has to be thoroughly assessed, including muscle strength and reflexes. You know, when someone's in your clinic and they are having symptoms that reflect hyper or hypokalemia, though you're doing a comprehensive head to toe. But there's some things you can really be provoked to think about, that you spend extra time and inclusivity because of their symptoms and your possible diagnosis. Diagnostically, we're always assessing the degree of potassium imbalance, and that's through serum. We're looking at serum electrolytes, blood urea nitrogen and creatinine, and that's kidney function. Glucose, you need a serum glucose. ECG, 12 leads should always be obtained, and urinary electrolytes. So let's divide hypokalemia and hyperkalemia. So in hypokalemia, determine the underlying cause. It's essential. And we really, in order to do that, you need to divide your patients into 3 groups. And think this way. You've got the first group with increased renal potassium excretion and hypertension. Second group would be that same increased renal potassium excretion with no hypertension. And then the third group is normal or decreased renal potassium excretion. So even though that's a little complex right now where you're at, that helps you really get to determining the underlying cause. So you can at least keep those 3 subdivided groups in mind when you're considering hypokalemia. For hyperkalemia, you have got to determine renal status. There have been cases of elevated potassium when patients have been on Bactrim, which is a sulfa-based drug, ACE inhibitors, and alpha receptor blockers, and spironolactone. All those drug categories increase the risk of hyperkalemia. So if you determine that the renal status is normal, no renal disease, you want to go ahead and make sure that you exclude Addison's disease, hyperaldosteronism, diabetes mellitus, sickle cell, lupus, and amyloidosis. All those conditions are seen more frequently in someone with hyperkalemia. Differential diagnoses, it really caused by a variety of disorders. So I just want you to review on page 1110 what the other differentials are. I've already given you the diagnosis. We're looking at hyperkalemia and hypokalemia. But there's a couple things to keep in mind. Management, begin with identifying the underlying cause, as I've said earlier. And I want you to remember, it's usually readily apparent, okay? Because we can usually tell by assessing the serum what the underlying cause is. There's sometimes when it's a conundrum, but most of the time it's apparent. So most cases of hyperkalemia are due to either diuretic use or renal failure. And one of the things to keep in mind is a traumatic venipuncture can create a pseudo hyperkalemia. So you got to consider that too. At-risk patients need frequent lab analysis, so you determine that by their multiple comorbidities or the severity of the over or under potassium. So serum potassium before diuretic use is standard of care and within 1 to 4 weeks. That just has to be included in the management. Let's look for a second at acute hypokalemia and management, and then we'll look at acute hyperkalemia. In acute hypokalemia, treatment involves administration of oral or IV potassium supplements, and that's all determined on symptomology and the degree of severity of that depletion. If arrhythmias or any neuromuscular symptoms are present, those patients need IV supplementation. Now, in acute hyperkalemia, severe elevated potassium, which is 7 or over, it requires IV calcium. And one of the ways, when you see ECG changes, you've got to think this person needs calcium treatment. While they're on IV calcium, the ECG will be monitored periodically. And I want you to keep in mind, though, the calcium doesn't correct the underlying problem associated with the hyperkalemia. It still needs to be corrected, but you're trying to keep them from dying. IV treatment of hyperkalemia also is in the hospital is the use of glucose and insulin. Okay, and that is because I put or insulin, but it's actually and insulin. That helps. That results in a shift from extracellular potassium, and it pushes it into the cell. So once these patients have been stabilized, we can use or prescribe Kxalate to reduce elevated potassium. Referrals. I refer patients that have these types of problems to endocrinologists as needed. If it's evident that it's diuretic, they don't need to see an endocrinologist, but otherwise, any type of complicated situation, such as hyperkalemia and renal failure, they need to go to a renal specialist. All patients with life-threatening symptoms are hospitalized. We all know that as nurses. And those with acute renal failure and hyperkalemia, those people need to be urgently hospitalized. So patient and family education is going to center around diet education, educate on medicines that could elevate potassium and or supplement use. They need to be educated that they need frequent lab monitoring. They need to avoid chronic laxative use. And chronic hypokalemia, those patients need to avoid licorice. We know that can lower potassium. And last, if they are in a potassium supplement, they are not to crush the tablets before ingestion. Thank you.